Hey, everybody. Tonight's program, different than what you've heard in the last few weeks. This is a once a month. It's called The Compass to MS Care, Reaching Rural America and Underserved Communities. And for who I am, well, for those that don't know, I'm the founder of MS Views and News. I'm the president, and I'm also a multiple sclerosis patient that doesn't believe in multiple sclerosis because I don't have time for it, everybody. And you should not have time for it either. Make it live with you, not you live with it. And that's my saying all the time. Tonight's program is sponsored by Genentech, Novartis, Biogen, EMD Serono, and Sanofi Genzyme. So we want to say thank you to all of them for allowing us to do this program, for giving us the support. And next up, we have Dr. Aburashed. And Dr. Aburashed, Rany Aburashed, as many know, many just know him as Rany, all right? But I'm still calling him Dr. Aburashed. And he's the medical director of the Neuroscience Center of Memorial Institute Healthcare in, I'm going to mess this up, it's Owasso, Michigan. I wrote it down because usually I put an S before the W, but I did not do this time. It's Owasso, Michigan, and Dr. Bosser is going to be speaking about things to do with a comprehensive MS center. He's going to speak about MRI protocol, as well as addressing your needs that you have as an MS patient, health literacy, and a little bit more. And so we're going to let Dr. Aburashed come online. I'm going to step off, but before I do, I want to let you all know that try to keep your questions relevant to tonight's topic, all right? Just make them about what Dr. Aburashed is speaking about. It's not about COVID tonight, though some people might have some questions on that, and I'm sure the doctor will be able to answer. But if you have any questions, on the top right of your screen, there's a orange box, okay? I'm a little colorblind, so I have a hard time seeing that, all right? There's an orange box. You can click on that. You can type in your questions, all right? And I will be able to call them out later on. But in the meantime, let's get started. And by the way, for whoever registered and wrote in a question previously, please don't ask again, because I'm going to wind up asking you the same question again because I have MS and I forget. Haha. All right, let's get started. Dr. Aburashed, we are so glad to see you tonight. Take it away. I'll be back in, how much time you need?
Well, this is probably 45 minutes or so here, and then some questions, an hour. We'll see how it goes.
Great. So in 45 minutes, I'm going to come back online. In the meantime, let's get educated, everybody. Take it away, doctor.
All right, thanks so much, Stu. Thank you, everybody, for logging in, and I see there's quite a few of you who are on right now. So nice to meet everybody. My name is Rany. I've done a couple of these with Stuart, really several of these over the years, but this year I think I did one earlier in the year, or late last year. So if you don't know me, my name is Rany. I am a neuroimmunology MS specialist here in Michigan. I'm the chairman of the Memorial Institute for Neuroscience. So we're a large group of 13 neurologists with multiple kind of silos within that group. We have a very large MS group with 3 neuroimmunologists and a neurovestibular neuro-ophthalmologist, as well as a neurorehabilitation specialist. And so that's really kind of what we're known for as a group. And so I've been actively, participating in trials and treating MS patients really at this point for greater than 11 years, and really passionate about what we do. So we're very active in research. I want to thank Stu again. I don't think Stu gets enough thanks for putting these things on. I don't think people realize how much work it is. One, he has to deal with doctors like me, and we're not very easy to deal with. And so, Stu, I apologize for that. Two, really, there's a lot of coordination that goes into these. So, and I think, his heart is in the right place in terms of getting information to patients and really helping you understand different facets of your disease and different little angles. And most patients who've come to these talks always tell me that even if they've gone to 50 of them, they pick up something, or something kind of sticks with them that maybe helps them understand what's going on. And so I think today's topic is really a great segue into that. And I'm going to break this topic down really into 5 different subtopics. So I will call those out to you so you understand them as we go, and then hopefully you can take something away. So with that, I'll start with the first of the 5, which is really understanding the importance of a comprehensive MS team and what that gives you as a patient. So I think a lot of times we talk about comprehensive care, and the thought process is, care in its totality, or someone who who really understands the disease, but it's much deeper than that. And as someone who's built a comprehensive MS center from really nothing, I mean, we started here in the middle of nowhere where our office is, and I was the only neurologist. There's a lot that goes into it. And as a patient, I can tell you, having the ability to be cared for in a center that focuses on comprehensive care really can have a profound effect on your well-being and your quality of life. And so what does that mean? So comprehensive care in multiple sclerosis, to me, at least, means that we have the ability within our facility and within our privy to tackle every issue that may come up with a particular MS patient. So it's not just about being very good at diagnosing multiple sclerosis or starting you on drug X, Y, or Z. Once, if you have that, if you're able to do that, that's great. But if you can't add into that the ability to take care of all of the tiny idiosyncrasies that occur throughout an MS patient's life, and to understand kind of what effect they may be having, what things are side effects, what things are actual MS exacerbations, what things maybe are pseudo exacerbations, really it falls on deaf ears. So to me, a comprehensive MS center includes the following. So one is really a MS clinician or someone who has a ton of experience treating multiple sclerosis and diagnosing multiple sclerosis. I also think it's someone who typically has access and the experience of using every MS treatment available at some point. It doesn't mean they don't favor X, Y, or Z, but the ability and the understanding of the complete broad landscape of MS therapeutics when it comes to the disease-modifying treatment. So that's kind of the cornerstone and the beginning of an MS center. When you add on to that, there needs to be an MS nurse, and the MS nurse is really your tunnel into the practice. It's your ability to communicate on the daily basis or every other day or every month or whatever it might be, where you have access to kind of that middle person between you and your clinician. We have an MS nurse here named Paige who does a remarkable job, and every day at the end of the day, her and I sit down either on the phone or in person, and we run through a slew of patients that, have issues throughout the day. And she does a fantastic job of kind of communicating back to that person and letting them know our plan and what we're going to do in the meantime, because MS care is not about the 2 times that I see you a year, the 2 or 3 times I see you a year. It's really that in between that matters. So if you don't have that point person, my schedule is really tough to kind of get a hold of me. A lot of patients do with my cell phone, and many do, but I can't do every patient in that way. And so it's huge to have that. So you have a clinician at the center with a ton of MS experience who has access and experience and knowledge with all the drugs. You have an MS certified nurse who has an understanding of the disease process and works specifically within the MS space, as opposed to doing everything in neurology. Number 3 is the ability to have a social worker to help navigate some of the insurance pitfalls that can occur when it comes to treatment, and really kind of help with some of the things that patients maybe don't think are our job. So we have social workers who help with child planning, child care, figuring out ways to get people to and from their appointments. If we're infusing someone, we have social workers that help patients get here from a transportation standpoint. Heck, we have our social workers make sure people get food, if they're waiting too long or so on and so forth. So those are three of the first 3 components. The next one is to have a neurorehabilitation component. So we have a neurorehab physician who is a part of our team who's embedded in our office, and I refer to him quite a bit. He's fantastic, and his focus and training is entirely on the mechanics of your walking, and understanding what braces are available and what braces you need, as opposed to me, who's not trained in those types of musculoskeletal mechanics, telling you, oh, I'm going to give you an ankle foot orthotic, and to me they're all the same. They're ankle foot orthotics. To him, every single one of them is different, and so he'll pick the right one for your particular case and get you into a brace that is comfortable and something that actually improves your ambulation and helps you quite a bit. So a neurorehabilitation person is important. Having access to a pain clinician is very important to comprehensive MS care, because there's a ton of pain that's involved. And so we've built all of this under one roof to provide our patients with, not every patient needs it, but when we need it, it's nice to be able to do that in a very streamlined way and have that complete care package. The next one is a urologist. So we have a urologist who does neurodynamics for us, who treats all of our MS-related urinary issues, whether it's Botox or whether it's just a treatment with oxybutynin or some other type of drug to help patients with their urinary retention or their urinary incontinence. We also have, to a lesser degree, because we don't use this a lot, we have access to a GI doctor who deals with manometry issues and deals with slowing of the gut and constipation, which sometimes can happen in chronic MS in a lot of patients. And again, that's someone who we don't use every day, but when we need them, we have access to them and they have experience and understanding. We also look at neuropsychology, the ability to understand the cognitive changes that are occurring in an MS patient. And so all of these clinicians are a part of the greater team, and they make up the greater team. And that greater team as a whole is able to kind of take an individual case, and we know that when we see a patient in the clinic, that we are able to kind of tackle any and all issues that they may have. And, our pain doctors will do the backlift and pumps if that's necessary. Dr. Azu, our neurorehabilitation physician, can do that as well. And in the end, when you start taking on cases, you learn very rapidly that if the entire team understands the entire disease, you end up with really this envelope of care that, I always tell our team, the goal is to provide a blanket to our patients. We need to be a blanket that surrounds them and protects them and kind of guides them. Again, there's a lot of moving parts to this, and it's not always perfect, right? It's easy to talk about it. It's very hard to implement this. And so, I'm very proud of what we've been able to do in this way. But for those of you that are out there, understanding that this type of care is available to you around the country is very important. And I can't stress how much I think it will help you as a patient if you go to a place that has access to these things and that approaches the patient care in this way. It's really a philosophy of patient care. And so, understanding that this shouldn't be, a 2-visit-a-year type thing where we put you on a drug and then you pop in and we say, how you doing? And if you're having a great week, you say, I'm doing really well. I exercised this week, I walked, I did X, Y, or Z. And as a clinician, you love to hear that because you say, oh, they're doing good. I don't got to do anything. This is an easy visit, and patients are on their way. But the reality is that the ebbs and flows of an MS patient are really where the juice is, and it's really where understanding if your treatments are working or not. So I would encourage those of you who don't see or who have not sought a comprehensive evaluation to seek that out. I think there's a lot of things that maybe patients feel can't get better that maybe can when it's dealt with in the right way. And that's not to say clinicians who are out there, not in these centers are doing a poor job. No, it's simply a byproduct of the realities of time and allocation of resources. And so when you're busy and you're seeing every type of neurologic issue every day, it's much easier to say, you're doing well, things are fine, you call me in 6 months, as opposed to where we really are trying to focus on every facet of what's going on with you. Another piece to the comprehensive care team that I forgot about is really the research team, which I think is important. The ability to have access to phase 1, phase 2, phase 3 trials, to be doing our own trials. In a disease that there is no cure for, it's very nice to in certain cases, be able to tackle this in a different way. And so I think those are things that should be focused on and reasons that I would personally seek care at a comprehensive center if I had this disease, God forbid. So that kind of caps the first topic that I want to talk about. The second topic that I wanted to dive into today was really discussing MRIs and MRI protocols. And I think a lot of people have questions about this. Many of you are considerably educated about multiple sclerosis, and you guys read a ton, which I love. And I have patients who, I got to text back a patient later on today who asked me a vaccine question that was really an astute question, and there's no clear answer for. And so, a lot of patients know a lot. So one of the things that I think many patients have been asking me about is, what's the difference between your MRI and someone else's, and what are we doing? So the first thing I'll tell you is not all MRIs are the same. So just because you have an MRI unit doesn't mean it's the same. So MRIs are magnets that come in various strengths. And those magnets can be, they're measured in a unit called Tesla, like the cars. And there's 0.7 Tesla magnets in some places on mobile MRI units. There's 1.5 Tesla, which is the most common, which is a good scanner that gives you good images. And then there's 3 Tesla, which sometimes you'll see. And in our new facility, we'll have that all set up, which is, really kind of the top of the line for commercial use at this point. And then there's even 7 Teslas, a few of them at least around the country, that are used for research purposes only. The idea behind this is it's very similar to your iPhone, right? So it's really a matter of how well the image is in terms of the pixelation and how sharp the image is and how much detail we can pick up on. Obviously, the higher resolution MRIs give us more detail, give us more insight as to what your lesions are doing, and can really give us an idea as to whether lesions are in fact enlarging or shrinking, and if there's any change. So you'd be amazed at the difference if I took you as a patient and put you on a 1.5 Tesla magnet and then put you on a 3 Tesla magnet. So same exact patient, same exact day, I will see images and lesions on the 3 Tesla unit that I did not see on the 1.5 Tesla unit. And so it's something that, when you first start choosing MRIs, I don't think you need to get all hung up on 3 versus 1.5 at this stage, because all of us have used 1.5s for years, and they're great images and they work very well. But as we go towards the future, I think understanding that imaging continues to advance technologically, and we're getting better at it, and we're getting better pictures, just like our phones are getting better and the cameras are getting better. So we really want the best image. The next is really how focused is the image on an MS patient. And so what I mean by that is that, obviously we're a comprehensive MS center, and we have an entire MS protocol that's different than our normal MRI of the brain. And so, a lot of places will just do an MRI of the brain. That's the vast majority. If you order MRI of the brain, you get an MRI of the brain, and they'll do certain sequences. They definitely get the bulk of what you need. There's no question about it. But there are some more refined sequences that can show us certain things that maybe we didn't pick up on as well on other sequences. So many of you may have heard of the central vein sign, for example, which has kind of been a hot buzzword in multiple sclerosis over the last year or two. The central vein sign is felt to be a diagnostic. It's supposed to help us with diagnosis of MS, and felt to be very specific to multiple sclerosis, that we see a kind of this vein in the middle of a lesion. But if you're not looking for that in a certain way, and if you're not doing scans in a certain way, you may not see that. And so, we have a set of protocols that we use that we feel give us the best images at capturing lesional change, capturing atrophy, and we use the software for that to kind of do that. So, and that would be an add-on. So we have a software that actually looks at not only we don't just look at your lesions, we also want to look at how much the brain is shrinking over the course of your MS. So we use the software for that, and some places do around the country as well. And it's really kind of, all that information is useful to us, because every inkling of information that gives us any evidence that your disease is progressing or potentially changing or evolving helps us make a treatment change if it's needed at an earlier time. So when you think of kind of what the future of MS is and what we want, there's 2 things that we're looking at. Number one is, can we personalize care to your specific case in a way that we know will work? So kind of the holy grail of MS is can I do a battery of tests or do a variety of things with your case and say that you need to be on drug Y, and that drug Y is going to work for you? And that is kind of something that we're working on from a research standpoint here. And that's kind of a very exciting thing for us to kind of try to figure out. It's not easy, but it's fun. And so that will eventually come to fruition. So that's number one. And number two is, so get you on the right track. Number two is, can we pick up the whisperings of your multiple sclerosis wanting to change before you do as a patient? So can we pick up elevated levels of inflammation? Can we pick up changes in your MS or changes in your disease state that we otherwise might have had to wait until the shoe drops and you develop a symptom, right? So it's easy when a patient comes in and says, "Oh, doc, my left arm went completely numb," or "my left leg went completely weak." It's very different when I do something like a scan or some type of monitoring scan, and I see kind of inklings of change that are preceding that potential weakness, and then that allows us to potentially change treatment, to put people on different drugs at a faster rate. And that's an exciting part of this as well. And we're getting better at that. We're using a variety of things, but MRI and atrophy measurements are a big piece of this. And so getting scans yearly, I tell every patient, a lot of patients don't want to do the scans once a year. And in the past, there was that huge issue with gadolinium and deposition of gadolinium contrast, and people had a big issue with it. That's been sorted out, we think, almost completely. And so what I would say is that yearly scan is really more important than you think. And I get it that a lot of you come in and we say your scan is stable, but you'd be surprised how many are not stable. And so I think I cannot underemphasize how important that yearly scan is. I want to tell you a story about this week in particular. I don't even know if this patient's on, but I hope he's on. He'll know who he is. I've been taking care of a gentleman with what I would consider mild MS, mild to moderate MS, really for, I think it's been 7 or 8 years now. And we've scanned him year in and year out. He's been stone cold stable, and he's an older gentleman. I think he's in his mid to late 60s now. Not old, for those of you who are 60, but older. From an MS standpoint, we think of 20s, 30s, 40s, really. And so, not a guy who really has had any evidence of disease activity over the years. He's doing really well. Well, we did a scan on him in January of this year, and lo and behold, for the first time, he had a new lesion, and it was active. And he's been on the same drug, hasn't missed a dose, things were fine. But that yearly scan, that patient feels fine. He has no symptoms right now. But that is a sign of a breach in the blood-brain barrier. It's a sign of his MS wanting to kind of get a little bit ugly with me. And so, we have a long conversation at that point about how we approach this, and do we switch drug? And if so, how do we switch? And what do we switch to? And so on and so forth. But if you're one of the patients who hates the scans, I get it. I've had one. They're awful. I hated mine. So I totally empathize with that. But I also can't underestimate how important it is to us in terms of monitoring you in a way that I think is needed. So that's kind of the importance of MRI and why I think as a patient, it's something that you should focus on quite a bit. So that closes topic 2, and I'll enter into topic 3, which is really kind of a much more modern topic, which is understanding telehealth and really looking at what those options look like and how do you as a patient leverage this technology in the current state. So this is kind of an exciting topic because we've worked quite a bit in this, and we had been doing this really pre-COVID, because those of you who don't know where we are in Michigan, we're about an hour from every big city in Michigan. So we're in a great central location, and most of our patients drive in from all over the state and really from around the country. But those in the state come in from within an hour or so. But this is always an issue because we get winter, we get snow in the winter here, and people don't want to drive, and I understand that completely. And sometimes they're doing great, and they don't need an hour visit, and they don't want to make that drive. So we had been looking at telehealth and kind of building. We've used telehealth to some degree in our place, not in the outpatient center, but in the inpatient center for a long time. Now in the outpatient center, COVID kind of thrusted this upon us, and honestly, it might be the one good thing that came out of COVID. When I think back to it, because telehealth has really helped us in terms of not only giving patients easy access to us. I can do a telehealth visit much faster than I can do an inpatient visit. An in-person visit. And what I mean by that is, for those minor issues that pop up, it's very nice to be able to throw someone on the schedule amidst a chaotic day. And even if it's just 10 minutes where I can talk about, this new urine thing that's going on with patient X, Y, or Z. And then the beauty of it is the visits are quick enough that I can say, let's revisit this with another telehealth visit in 2 weeks. So instead of saying, we'll talk about it in 3 months, or we'll talk about it in 5 months, I can literally just kind of walk you through this symptom, get it resolved, and then we move back to our normal kind of twice-a-year visit. So that's been a huge advantage of telemedicine, and something that I've cherished with telemedicine, and I love that aspect of it. As a patient, understand that it's made your world very small now. So you now might be in California and might have access to any MS clinician you might want. So depending on insurance and there are ways to do that, but it gives you access to choose your care and to make sure, even if it's just to say, hey, I want a second opinion, can you look at my case? so on and so forth. So we've started to use this quite a bit. And so prior to COVID, we had patients from I think it was 21 states visit us in Michigan for care with MS. Post-COVID, we're up to 44 states. And the other 23 have all been new established patients from a telehealth concept. So patients who have called and said, I want a second opinion, can you review everything? They send their MRIs over, so everything's FedExed over to us. It's basically the same as an in-person visit, other than me being able to examine you fully. I examine you. I can do that over the video. So if I have you put your arms up, have you touch your nose, look up, look down, look left, look right, smile, show me your tongue, walk around the room. And if you have somebody there with you, I can even walk them through some of it to get more pieces to the puzzle. But it's really nice to be able to talk to patients and kind of look at their MRIs and look at their cases and discuss kind of, you know, where they might be. A lot of times it's hey, I live in, I don't know, the middle of, you know, Indiana, you know, and they'll say, you know, who do you recommend? And I'll say, oh, I have a good friend there who's an MS specialist. Why don't you take a look at this gentleman or this woman? And so it helps patients, I think, a lot, not only access people who we trust, because the MS community is very small from a clinical standpoint. So, I mean, it's so small that Stuart even said Dr. Buster in the introduction. I don't know if you caught that. I did. Stuart probably did. He's rolling his eyes right now. But I mean, it's a small community. You know, there's not a ton of MS specialists in the country. I want to say there's 200 and some doctors who make up about 60% of the MS care in the United States. So it is a very small number, and we have 3 of them here in our center. But you know, we can get you to where you need to be depending on what's going on in your case. So I would say, as a patient, depending on where you live and what resources are around you, using telemedicine is a huge advantage. And so, you know, we take consultations for it all the time, and I've enjoyed doing it. I think it works. So is this the ideal way to speak to you? No, I'd rather be there in person. It's always better that way, but you know, in a pinch, this works wonderful. And you know, you guys are all at home. Some of you are drinking tea and coffee or having dessert after dinner. And you know, it's not the worst thing to jump on for 30, 40 minutes and learn something before you start to Netflix again. And so using this technology and leveraging it's very easy. And even if you just have a phone, we can use it and we can set you up. So I would say, as a patient, you know, use it. Don't be afraid to kind of reach out, do some research, and figure out exactly where your care needs to be and how you want your care to be. So that's telehealth. The 4th topic I want to talk about was health literacy. And health literacy is really what we're doing right now. And I think, you know, Stuart added this topic, and I think it's a brilliant ad because I think a lot of patients don't understand. So one of the keys as a patient to understand is, the more you understand your disease, the more you know what's out there, the more you understand what options you have, the more likely you are going to be to push your clinician to really focus on what's going on. And this sounds terrible when I say it like that, but what I mean is that if you are laissez-faire about it and know nothing about your disease state, and you are completely dependent on, you know, how good your particular doctor is, or do they make the right decision today, you know? And the vast majority of times, most clinicians do, and that's a beautiful thing about medicine is you know, we have kind of an understanding of what people need. However, the more educated you are, the more we're able to, you know, the more you're able to push us and really make us better at our job. So I think, as a patient, health literacy means not only reading about MS, but you have to truly understand the disease. And I have patients that, in my opinion, know more about multiple sclerosis than a lot of people in the healthcare field. Frankly, I mean, they can tell you where the clinical trials are. They can tell you what drugs and compounds and molecules are being tested. I have had a patient text me something before I saw it. And it was pretty amazing. And I said, I haven't seen that yet. And they sent me the article. And that is the true definition of health literacy. I mean, health literacy is you no longer are dependent on me to tell you everything about what you need. It becomes a team approach where, yes, you trust me, and yes, you know I have expertise. However, I know you have expertise. And then the conversation becomes an entirely higher level, and the decision-making becomes an entirely higher level. So, getting educated on kind of what you need, what you may or may not need, and understanding what may be available, I think is something that you as a patient should take on yourself. One of the things as a patient that I think people lose sight of from the patient role, and I had this talk today with a patient, and I hope she's not on because she's going to be mad at me. She's probably smiling right now because she's the sweetest woman. But, COVID kind of got her down a little bit, and she's been locked up in the house and not doing a lot. And she's got the ability to be active. She's just not, and she's kind of depressed. And I said, listen, 50% of your care is on me. My job is to put you on the right drug. My job is to monitor it safely. My job is to make sure nothing's worsening and to monitor you X, Y, and Z. I said, but 50% of this is your job too. Your ability to exercise, your ability to diet correctly, your ability to keep yourself in a good mental state and manage your stress levels. And I think it kind of took her aback a little bit. And I said, look, it can't all be me. I mean, I can do the best that I can do. And if you're not helping me, we're only going to get to a certain point. So as a patient, I think health literacy fits into that mold as well, where, I need you to know what matters. I've had patients who weren't very health literate, who developed relapses that were minor, but had no inclination to call me. So, I've had patients who said, oh, I just thought it was a little bit of numbness in my hand or whatever. It's no big deal. Well, to me, it was a huge deal, right? I mean, to me, it indicated that his drug was not working or her drug was not working. And it indicates that I needed to act. And so the more literate you are about your disease, the more likely you're going to be able to actually become not just a byproduct of, you're no longer a passive observer in your care. You're now an active participant in your care. And so as a patient, I would tell you that I expect that from you. If you are my patient and you're on, you'll know I oftentimes say, hey, I need you to go into Rocky mode. And what I mean by that is, the training scenes in Rocky, the movies, where I need you to really kind of, this is not a joke. I can't tell, you can't just nod your head and say, hey, yeah, I'm going to work on quitting smoking. I'll do my exercises, and they'll sit down for a few days and bring their leg up a couple times like this. And then it kind of goes away, because that's not going to get us anywhere. At the end of the day, when we go into Rocky mode, it's a completely different mindset from a patient standpoint. And you are in the middle of a fight, and I'm right there with you. I mean, I'm fighting with you side by side. But you got to do the heavy lifting. I might be Mickey sitting behind you yelling and screaming, but you're Rocky in the ring. And so, I'll guide you, I'll coach you, but I need you to kind of pull your weight when it comes to this. So get educated as much as you can. Go to talks like this, get different perspectives, right? I mean, MS is not this is a heterogeneous disease, meaning every case is different. It's also a heterogeneous disease when it comes to the way clinicians approach it, the way doctors approach it. So, who's to say that I'm right? I do what I think is absolutely correct. I mean, I do what I would do in myself, but there's other doctors who might approach it differently. So understanding their perspectives and getting that information doesn't bother me one bit. I actually would condone it and think it's just the right thing to do. I'm confident in what I know and what I do, but I'm also confident that I don't know everything. And so it's a good thing as a patient to take that on and not be afraid to do that. And honestly, if your clinician gets insecure about that, I think it speaks to their how comfortable they are with their degree of knowledge or their base. So I encourage it, and I think it's important to do. So work on health literacy, continue to build that foundation, and then layer it on with more and more stuff. People ask me, how do you do that? You start with the basics. You start with a simple Google search and understanding kind of the basics of MS, and then you kind of start diving in. So, when you see an MS drug's name, research it. Just, type in drug Y and start diving into what that drug looks like. Ask your doctor the next time you're there, hey, this drug, how do you classify that drug? Is that a strong drug? Is it a weak drug? Is it a safe drug? Is it a risky drug? I might say, oh yeah, that drug on paper looks great, but in reality, we've used that drug for years and it does the following, and we don't want that. And so that's kind of that's where health literacy helps a lot. Whereas otherwise, you never hear about it, you never know. And I'll close with the final topic of today's talk, which is really effective communication with providers. And this is something that's near and dear to my heart because I think it's something that takes both of us, both the patient and the clinician. But I cannot stress enough how important it is to be able to understand what the heck your provider is talking about, to truly understand, not to hear them, but to understand what they're saying, and to apply that to your treatment decisions as you go forward. So effective communication means that we have an open relationship, a rapport that is natural, a rapport that is very real and is not kind of static. So I'm going to be myself. I'm going to talk to you. Look, I'm giving this talk. This is how I speak to you if you're my patient. Your doc's not the Pope, and you're not at their disposal. I mean, it is a team thing where you need to feel comfortable enough to say, hey, doc, here's what's going on, and your doc should respond in a way that really makes you feel comfortable. I mean, my job at the end of the day is to, 1, get you on the right treatment, 2, give you reassurance, 3, always give you hope that is based in reality, not based in fantasy, and 4, make sure that I'm doing the work that you need as a patient. And your job as a patient is to make sure that you feel comfortable enough to call me and say, hey, something's happening, or I'm worsening in this way, or I feel like this drug's not working. From a clinical standpoint, as a doctor, there is no one that can get me closer to what's happening with you than you. And most patients, most of you know what's wrong. Most of you can tell me this isn't working. And my job is to listen to that and not tell you that you're wrong and I'm right, because you're in your body. I mean, you are feeling what you're feeling. I have to vet it. I have to go into it more and examine it more, but I have to hear it. And as a patient, I think, if you don't have a relationship with me where you feel comfortable doing that, you're really going to run into an issue long term, and you're gonna find yourself in a situation where you leave the doctor's office and none of your questions are answered. You are more confused when you leave. And what the brain does in that situation is it latches on to the 1 or 2 things you did understand. Well, and this happens to all of you, where your loved one didn't come to the visit with you, and then you jump in the car and you get on the phone with them, and they say, "Oh, how was your visit with the doc?" "Oh, it was good." "What do you say?" "Not much. I mean, yeah, we're okay. Oh, we're gonna switch drugs. Yeah, and that's it." And the loved one on the other end is like, "Whoa, what's the drug you're going on? What are the side effects? What's the risk? What's the risk with it? How are they going to switch it? What's going?" And so you lose all that information, because if you don't have a relationship with your clinician that's really grounded in something strong. And so we've tried to work on that in our clinic. So one of the ways we're doing that now is a new discharge summary that you get, where we actually in the room will, and I admittedly, I'm learning to do it. I'm not good at it. My other partners are better than me at it, but I'll get better at it, I promise. But where we kind of write down the summary of the 5 or 6 things. So I tend to kind of tell you what we're doing. So here's what we're doing today. When we're done with our visit, I'll say, all right, we're going to keep you on drug Y. It's working well. We're going to get an MRI of the brain in October of this year, and that's your 1-year mark, and thus far you've been stable. We're going to order the following blood work today. We're going to start you on the following medication for your spasticity. We're going to change your antidepressant to an elevated dose of this. We're going to get physical therapy involved, and then lastly, we're going to set up, this whatever urinalysis or this urodynamic test for your urine issues, or start you on drug. You kind of get those 6, 7, 8 things in a row during the visit, and you walk out with that in your hand. And when your loved one calls you, you can say, "Oh, this is what we're doing: 1, 2, 3, 4, 5, 6, 7, 8." But if you don't feel comfortable communicating with me in a way that is natural, we're just not going to get there. I mean, it's just going to be this kind of, awful, overly professional relationship that really just is not natural. And in the end, what you want is a doctor who's very affable, and you want a team that's very affable, a team that's approachable. And I will tell you this is hard to do. So we do this very well, and we fall short many times. So whenever you hear me talk about these things, understand that I know how hard this is, and how busy we get, and things slip through the cracks, and phone calls are missed and not returned, as quickly as we want them to be. So it's really a challenge. And so just know that we're working on it, and we've developed a new model in our new center that opened either late this year or in January of 22, that we hope fixes most of these issues. And it's a new model of care for MS. And so we're very excited to bring that to you guys. And Stuart, I think at some point might bring that to the internet for us so you guys can see it around the country. But with that, those were the 5 topics I wanted to touch on, and I learned a long time ago that attention spans are short, and so I'd rather talk for 41 minutes and take questions than talk for an hour and a half and have you staring at your screen. So with that, thank you, and I'll open it to questions.
Wow, awesome. Thank you, doctor. I want to let you know people are texting me with praise about you, and they're like, they want to bring you to their next doctor appointment.
Oh, well, let's go. When are we going?
They want you to come with them to their next doctor appointment to show their doctors what they're not doing and what they feel that you can do for them. But they're very far away from you, otherwise they'd be going. And
Sure.
And I had like 3 people text into me about this, and I'm like, wow, this is great. I mean, Dr. Aburashed's doing a great job, So first off, I want to thank you for doing everything that you just spoke about. I definitely want to beat you up for some of the things that you mentioned my name about, because you said Stuart's probably going to kill me for this. But yes, I was listening about it, and but it's all good, all right?
Yeah.
For anybody that doesn't know, Dr. Aburashed is going to be opening up. Well, they're almost finished construction, and I'm sure a lot of it was delayed due to COVID, due to everything that happened in 2020. But Dr. Aburashed is going to have a new MS center, hopefully finished and opened by the end of this year. And when it's ready, I and my video team will be going up to Owasso to video record the center and get a tour from Dr. Aburashed and let everybody see what is in the center, so that way the world can know what he's done. Okay.
But can I see if you can see it? I don't know if you can see it from my window, but I'll try to give you a look.
You can try.
Can you see,
It would probably be better if you pulled up the shade.
Yeah. Well, do you see that building out in the distance?
No, but I did see the Porsche sitting in the first spot. Was that yours?
Yeah. You see that building out there?
Yes.
So that's
Great.
our new center. So it's 100,000. It's
Fabulous.
basically like a
It's
mini neurology.
There's plenty of place for me to park too. That's great. 100,000 feet.
100,000 square foot center, and it's it's built with MS patients in mind, and so it's our new institute. It's got an entire research arm, an entire rehab arm, an entire medical equipment arm, but it's going to be very cool. We've done some really cool things in it, so we're excited.
Okay, great. That's fabulous. Thank you. All right. Well, we look forward to doing this. I look forward to seeing you up there. I don't like the idea of going up there in December. I mean, you're talking about a guy that's used to 80 plus degree heat, and I mean, I'm going to have to pack with a double Parker on or something, with the puff jackets to get up there and get up there to see you. All right. But
I'll pick you up with a jacket, Stuart.
If you build me a nice fire, I'll be there. Okay. Just don't make it of the center.
No
All right.
worries.
We have a lot of questions to go through. We did get people asking questions online, as well as those that ask questions when they register for the program. I'm just going to shoot through them. I believe that you'll be through them in adequate time so you can get home to your kids. All right. All right. Great. All right. So the first one. So anybody who asks online, I am going to mention your first name, just your first name. And believe me, nobody's going to know it's you unless your name is Aloysius Diddlehopper. All right. That's the only way they're going to know it's you. All right. Otherwise, if there's a Linda out there, well, there's thousands of Lindas out there. All right. So I'm really not going to worry about it, and neither should you. All right. From those that ask questions first, where can people with MS who are doing everything they can find clinical trials for remyelination?
Yeah. So this is a huge question. So when it comes to remyelination, obviously this is the next frontier in multiple sclerosis, and it's really something that we have to tackle and we have to figure out, and we will. It's been a pain in the butt thus far, and so there was a clinical trial that we just closed recently at our center. So there's not many compounds. Number one, the big ones are elezunumab, the Stanford compound, and then there was a compound called anti-lingo that didn't work out as well. So the first step I would tell you is there's not a ton of trials for remyelination. So don't think that there's like all these things happening around the country and you're just missing out. There are isolated places that are doing trials. The best way to find out, so if I was a patient, how I would dig into this is the following. I would start by looking at the comprehensive MS centers on the National MS Centers website. I would start there. Once you know where the comprehensive centers are locally or close to you, I would go to each one's website individually, okay? So if you go there and you see our institute, you would see that would link to our website. And when you went to our website, it would then give a drop down, and some websites, there's a drop down of all the active trials. And if there's not, a simple phone call saying, can you send me a trial sheet, is all you would need to do. So it's a little bit of legwork on you. You don't see this, this is not something most people advertise, but if we sent you our trial sheet, I'm wondering if I have one in my office. I'd love to show you what it looks like. It would give you really a great idea of what I'm talking about, because it's an Excel sheet that literally goes through the 29 trials that we have actively right now. And that's where you're going to probably find, the answer to your question. So for me, offhand, to tell you where to go, I don't know where you are. But if I got your information, I could probably guide you a little bit if you can't figure it out this way.
Okay. Thank you. By the way, if anybody goes to, what is it? Which is the gov site that people could go to?
Clinicaltrials.gov will
Right.
tell you trials are out there, but it won't tell you where they're being done. So
Okay, gotcha.
you can see who the primary investigator is, but usually what happens is those trials kind of start with a pharma company, and they have a primary investigator who's the main person for the trial. However, there might be 15 or 20 sites around the country or the world that are doing it.
Okay, great. Thank you for that. All right, next person wants to know how they can participate in your clinical trials for biomarkers, and if people are still being enrolled.
Oh, absolutely. So great question. So someone who's familiar with our work, and I love that. So, those of you who don't know what they're talking about, so we have a machine. Should I take you to the machine? I have it. It's next door to me. You want to see the machine? It's kind of cool.
Go for it. Go for it. It's a great idea.
So we have a machine called a single molecule array assay. And so, we have one of the only ones in the country. And it's right next door to my office. So I'll just walk you over. No one's here anymore. So, this is Miles right here. So this machine is called a single molecule array assay. It's made by a company called Quanterix. And it's very unique in that it gives us the ability to measure proteins in your blood down to picograms per deciliter. So we can look at really the smallest molecules that are coming out of your brain and measure them. So I measure a variety of molecules. The main one that people are familiar with is something called Neurofilament Light. And we've been doing that now for 18 months, but we were on pause for about 4 months with COVID. So really in total 14 months, and we have a ton of data. We have over 1,000 people in our database now. However, we are still enrolling patients. We did not cap the number of patients. We want as many patients in this trial as possible. It would take a visit to us, and depending on where you live, we would have to coordinate how we could get this done. If you're on the outside, we have done it with people out of state. It's a little bit tricky, but we find ways to do it. And so that would be kind of a one-on-one question. So if we did a consult with you and understood your case, we'd know where you'd fit in the trial. But so neurofilament light is our main marker, but we also have 5 other markers now that we are looking at in conjunction with the neurofilaments. So it's been a labor of love, and it's very hard work. It's not easy.
Great. Thank you for that. Now, being the inquisitor I have to be, and since you opened up the door on this, you talked about neurofilament light, or NFL as we also know it, and a lot of us might know what it is, but I'm sure there are people on here that have no clue. So you could tell them, can you please tell them what this is about?
Yeah, absolutely. So neurofilament light is a protein. Hey, you know what? I'm going to do you one better, Stuart. I'm going to show you what it is. Let me just log in.
Show them.
I'm going to show them what it is. I'm going to log into my computer, my work computer, and I'll show you.
Right now, we're only seeing the scruffles of your face.
Hey, listen, it's COVID. I don't have to shave right now, and I'm really tired, Stuart. Okay, give me a break. So neurofilaments are proteins, and I hope you can see this. Can you make that out, Stuart?
Yes. Can they make it out? Yeah. Yes, too.
And I hope you can make it out. Okay, so when you look at a page, so this is a picture that we developed. So please don't share this if you take a screen. I mean, you can have it if you want a screenshot, but it is copyrighted to our team. But nonetheless, so you can see a nerve cell here, and you can see the myelin here in purple, which is the outer edge, right? And then you see the axon, which is the actual, the wire. So we always talk about this in terms of there's the copper wiring, and then the covering is the myelin, right? The insulation. Well, underneath the axon underneath it is a scaffold that kind of holds up and increases the surface area of the nerve cell, right? That scaffold, think of it as a foundation. It's a foundation to a home, for example. So it goes underneath the home. It's the concrete underneath the house. It's made up of proteins called neurofilaments. There's really 5 of them. It's a heteropolymer, but there's 3 main ones: neurofilament light, neurofilament medium, and neurofilament heavy. And as there's damage to this structure, those neurofilaments leak into the spinal fluid and eventually into the blood. And that's where we measure it in the blood, okay? So what does that mean? Let's go to another picture for you that we developed. So this is my model of neurofilaments, and I call this the neurofoundational model. And so when you look at a normal, can you guys see this, Stuart?
Yes.
Okay. So when you look at a normal nerve structure, a normal group of cells, you have the myelin on the outside, and then you have the axon, which is underneath the myelin, and then underneath the axon lives the neurofilaments within it. It kind of holds it up, right? So if you think of it as a model of a house, you have the foundation underneath, the axon would be the house itself, and the myelin would be the roof. So let's imagine that the roof of a home is on fire. Okay, so the myelin is on fire. We do an MRI and we see an active lesion because the roof, the myelin is on fire. Well, it might look really bad on the MRI. However, the foundation of the home and the axon, the home itself, appear to be intact. So once this fire's gone, we have to replace the roof. There'll be a little bit of work involved, but the house itself will maintain for the most part. Okay, so that's a certain type of lesion. What if there's an earthquake that really foundationally disrupts the home, knocks out the roof, knocks out the house itself, and causes structural damage? Well, when it causes that structural damage, it leaks neurofilaments into the blood. Okay, so I measure the neurofilaments in this patient. The MRIs between these two might look exactly the same. However, this patient's neurofilaments might be, I don't know, 15. This patient's might be 400 or 150, right? Much more structural damage, indicating a more significant attack, right? The last part is, what if the house itself looks great, but the sump pump breaks and you end up with flooding underneath the home, right? That you can't see, that's slowly eroding that neurofilament. And that level's elevated. The MRI looks normal because I can't see this on an MRI. But when I measure your neurofilament level, it might be 150, just like this person. So this would be that slow kind of degradation of the brain, that slow atrophy. So we measure neurofilaments in all of our patients as part of our trial to try to characterize kind of where they are in their disease state. So hopefully that helps you understand it.
That was an awesome description. I've never had anybody lay that out for us the way that you just did. And I'm sure, and I'm hoping that everybody that's online appreciated that as well. So I can't wait for others to see this and for us to be able to use that going forward. I wanted to let you know that. All right, next is a person named Linda that evidently is in your area. She says, I live in Saginaw and I see a neurologist at Henry Ford West in Bloomfield. Could the National MS Society direct me to an MS rehab therapist?
Yep. So, well, you're in Saginaw, so you're about 45 minutes from us. So you're not very far from us, and you're further from Henry Ford West Bloomfield. So where you want to get treatment would matter. I mean, it would depend. If you're in Saginaw, your drive to Henry Ford West Bloomfield is probably about an hour and 30 minutes or so. So to get into a rehab, program there might be a challenge depending on how often you have to go. The MS Society, what I would say is I would talk to your clinician at whoever you're seeing at Henry Ford and say, really, if they're going to keep you in that system, you have to ask them who they use for neurorehabilitation. I don't think the MS Society website will break it down for you by subspecialty. So it'll say comprehensive care. So they should have somebody that they work with who can guide you. So I would call your clinician first, and then see who they recommend. And then if you don't get answers there, maybe reach out to other places and see who's good. I have a name of someone that we use. He's in our office and he's fantastic, but again, it's not my place to say like, this is where you need to be, because they might have a fantastic person down there that I don't know about.
Okay, thank you for that. All right, next, I live in Idaho and we have communities that don't have comprehensive MS care teams, only general neurologists. What do you suggest?
So this is a great opportunity to work your general neurologist with your comprehensive team. I mean, I would leverage telehealth in this situation. So this would be a situation where maybe you have a consultation with a team like ours. We kind of go through everything, and we do that in conjunction with your neurologist in Idaho. So there's no reason that they would say no, unless, I mean, if you ask them and said, do you have any issues with me getting a second opinion by telehealth, but they want to work with you and as opposed to against you. So it's not about who's right. We don't care who's right. We just need to get you better. And so we can work as a team. And so we've done that before, where I have a communication with the general neurologist in a rural area and say, hey, I talked to Linda or whoever, whatever the name is. We reviewed her MRIs. Here's what we're seeing. Here's our recommendations. Do what you'd like, but this is how we would approach this. And if you have questions, let us know.
Okay, thank you. All right, next we're going to get into some MRI questions. The first is, how accurate is MRI with gadolinium, and are there any safer contrast dyes to use?
Yeah, so it's a good question. So the first thing I'll tell you is I'm not an expert in MRI dyes. I'll start by telling you that. And so this would be a great question for a neuroradiologist who's maybe an neuroradiologic engineer who's looking at this. So accuracy of MRI is really dependent on, first of all, MRIs are fantastic and they give us a lot of information, but accuracy is going to be dependent on how still you are. And if you move a little bit, it affects our accuracy. How long they wait between giving you the dye and doing the scan. So if they give you the dye and 30 seconds later you're in the scanner, you're probably not going to catch as much as if we give you the dye and wait a little longer. It's just in the US, we don't do that because we like to move people very quickly. And so I think, in terms of the actual contrasts, I honestly can't answer that question for you. I wish I could. Gadolinium, I assume, is the safest, and that's why we use it. But I will ask a neuroradiologist for you to see if there's anything on the horizon in terms of contrast, because I'm not educated about it.
Okay, thank you for that honesty. And going forward, Katrina asks a question that's in combination with one that I'm going to ask from paper, and that is, she's asking, is it okay to get MRI on with a 3T, and next time get it with a 1.5 without much discrepancy? And in addition to that, a person is asking, should I push for a 7T MRI, or is a 3T sufficient?
Okay, so you definitely don't need a 7T MRI, not yet. So a 7T MRI is going to be strictly research-based, and there's going to be a lot of noise on it that we don't understand yet. So it's so detailed that we might see something and say this means something, but it might not. So that's the first step. So I don't think that's ready for prime time. Katrina's question is a great question in terms of flipping back and forth between MRIs. So in the ideal world, we establish your baseline MRI on a unit, and then we continue to test on that unit as much as we can. And we keep you on the same unit as often as we can. The reality is we can't always do that. So it is okay that you go from a 3 to a 1.5, but I would recommend that you try to get, as much as you can, try to keep it uniform on the same unit. And that doesn't mean that, every MRI I've ever done was done at this hospital. You can start fresh with a new baseline right now, but I would just continue it. The more important thing is not to have, you want to be cautious about going through 50 different doctors. That's always one of the issues that happens with this, is you'll see a doctor, you get an MRI on the unit they use or that they're, at their facility, and then you don't like something about that person, so you go to another doctor and he uses a different, and then you end up with 12 MRIs from 12 different places. So first find the right doctor and then just do the MRIs where they recommend them. You know what I mean? That's my recommendation.
Sure, thank you. All right, next we have Elizabeth asking, does insurance pay for the 3 Tesla?
Yeah, insurance will not differentiate between the two. It's whatever unit I have.
Okay, thank you. Next one, how accurate is the MRI without the gadolinium?
So it's equally accurate. It just doesn't give us as much information. So the gadolinium, the reason we give the contrast is because we want to see if there's any breaks in the saran wrap that's covering your brain, right? There's this protective shield around your brain called the blood-brain barrier, all right? And so if we see, so that when we give you contrast, that contrast should remain in your vessels. It should not make its way into the brain. If we do see it leak into the brain, it tells us that there is an active lesion, that there is an active breach of the protective force field, so to speak. And so it gives us information as to timing of a lesion and how acute this lesion is. So it's very useful. I mean, does that mean you have to get it every time? No. I mean, I have patients who I'll do an MR without GAD, if they're very stable for a long period of time and there's really no inclination. But if I could get it with GAD, I'd always take it with GAD.
Okay, thank you. Karen is asking, is there anything more frustrating than your MRIs always saying stable and yet you're getting worse? This is why I hate getting MRIs.
Absolutely. And Karen, I totally understand it, and I empathize with you on this a lot. There is no question that there is a clinical radiologic paradox. We talk about this sometimes, meaning that clinically you're getting worse, radiologically you're stable. And you sit there in front of your doc and you say, "Doc, my left leg keeps getting heavier and heavier and weaker." And your doc says, "Well, your MRI looks stable, things are good, the drug is working." And as a patient, you're probably like, "Dude, I can't walk anymore." So I completely understand it, and it's very real. Now, there's a caveat to that. Remember that an MRI picks up, the focus of an MRI when we're looking at it from an MS standpoint is primarily looking at lesions. And so what that involves is the assumption that the lesions are all that matters, and they're not, because there's a whole other component to this, which is atrophy, or the shrinkage of the brain that's occurring kind of over time. And so naturally, human beings will have shrinkage of their brain as we get older. So right now, my brain is shrinking at a rate of roughly 0.1 to 0.4% per year. An MS patient's brain shrinks a little bit faster than that. So it can be anywhere from 0.3 to 1.3% per year. Some patients have normal shrinkage with MS. Some people have much more rapid shrinkage. And so some of this is just atrophy or slow degradation of brain tissue. So we use a software to measure that on our scanner. And so it's useful, but again, it's not perfect. But that's probably what you're describing there, Karen. I think it was Karen who said that. But I totally get it. I know it's annoying.
Okay, thank you. All right, next, is MRI needed if a patient has been stable for over 15 years?
Yeah, so it's very patient-based. That's a great question. I can't answer that in terms of just every patient. So it would depend on your case. But yeah, I do have patients who have chronic MS who really, it's really petered out, and we're past the point of concern at this stage. And so, there are times where I will make exceptions. The reality is, as a clinician, yes, we recommend an MRI every year, but you're also a human being who understands life and the realities. So if I think an MRI is going to be low threshold for me, I'm not going to get it. It's just a waste of money and a waste of your time. So I don't just do it to do it. There needs to be an indication. So if you've been stable 15 years, I think it's a conversation you have with your doc. What I probably would do in your situation, I say, listen, I'll make a deal with you. If you continue to be stable, we'll do an MRI every 2 years, just to kind of take a look to make sure we don't see anything. Something like that.
Okay, thank you for that. Next, can you discuss MS and sleep issues?
Yep. So that's an entire conversation, an entire lecture by itself, but I will try to answer it as briefly as I can. So MS patients typically have significant sleep issues. It's a very common problem to have sleep issues, and that can range from insomnia to sleep apnea to myoclonic jerks during sleep to hypnagogic jerks. So there's a variety of things that can occur during sleep that affect an MS patient. MS as a disease causes fatigue. So you end up with this cluster and this cycle of fatigue from your MS, coupled with poor sleep, which makes you more fatigued. And then you kind of are taking a medication like Provigil or Adderall. And so now you're hyped up, and now your sleep is even worse. And so it just ends up with this cycle of feeling like crud basically all the time, okay? So what I would urge to any MS patient who has a sleep issue is to make sure you get a sleep study from somewhere that your clinician trusts. That looks at kind of every aspect of your sleep, and start there before we start treating your fatigue with a treatment. Because we often reach and assume the fatigue is from your MS when it may just be horrible sleep and not restful sleep.
Okay, thank you. All right, next, since steroid infusion has the potential of thinning the bones, would you say that IVIG is an effective treatment for stopping an exacerbation?
So I'll answer that question kind of in two ways. The first one is the assumption is that steroid infusions thin the bones. So yes, steroids can affect the bones. However, we see that more so with chronic steroid use. So if you're coming in for a 3-day course of IV Solumedrol once every 10 years, it's probably not going to do anything to your bones. So it depends on the frequency. Now, if you're getting IV Solumedrol monthly, that's a huge problem. Then you really are going to be at risk for some bone degradation and a variety of other issues that can happen with chronic steroid use. So first, isolate how often you're getting steroids. The second one is IVIG a good alternative? IVIG is a fantastic infusion that we use oftentimes in certain cases where it's more severe. You know, I was part of a team that developed a white paper about MS relapses, and IVIG was included in it as a potential for certain severe relapses. So I don't think you'll get IVIG approved for an acute clinical relapse in most instances because it is very expensive. But yeah, in theory, it's a useful alternative in the right case.
Thank you. All right, breaking topic where we are a little bit right now. Cassandra has written a couple of times. She must want this answer. I have relapse remitting MS diagnosed in 98. Does bladder Botox cause frequent bladder infection? Because I've been getting Botox since 2007 and constantly been getting bladder infections.
So again, Cassandra, I appreciate the question, and I'll try to address it for you. Just know, you know, when I do these, it's very hard to give you a true medical assessment on these because there's so many factors. So I'll tell you what some of the factors that you should discuss with your doctor might be that might help you get an answer to your question. So the first one is when you give someone Botox in the bladder, the idea behind that is to paralyze or relax the muscle. The detrusor muscle is the muscle in the bladder that constricts when somebody is trying to urinate. So the bladder is like a balloon, and naturally when it's filling, it expands. And then when you're going to pee, that detrusor muscle will constrict and push everything down and you pee, okay? So we put Botox in patients who have an overactive bladder that's kind of overly pushing. So they develop incontinence and leakiness. So it gives the bladder a chance to relax and fill fully, okay? So that can be a nidus for infection in some patients, right? Because you are sometimes filling the bladder more than it needs to be and not urinating as often as you might have, okay? So that's number two. So yes, that can be it. So the first question to your doctor is, do you think the Botox is the reason that I'm getting bladder infections? But the second question is, what medication are you on for your MS? Are you on an immunosuppressive drug that might that might give you an elevated risk for bladder infections? Are you on Ampira or dalfampridine, which has about a 10% risk of urinary tract infection? So number four is, you know, what's hygiene like? So there's a lot of questions that go into it. It's not as simple as saying the Botox causes your bladder infections. So those are things I would. Yep.
Oh, continue. I'm sorry.
Yeah, I was just saying those are things that, Cassandra, I would discuss with your clinician. You know, as opposed to just saying what may be causing it. Just understand that there's a lot of factors that may be contributing to it. So you want to get that ironed out.
Okay, thank you for that then. All right, is there any specific age that a person should transition off of Ocrevus?
The short answer is no. You know, there's not a simple answer to this, and the reality is we don't know. So that's the second answer. Everyone approaches aging and MS differently. Everyone stops drugs in a certain way differently. So it depends really on the individual case and kind of what the MS looks like. As a hard and fast rule, we tend to really scrutinize patients over the age of 70 and start to really, for all treatments, not just Ocrevus, and start to think about whether they're a patient that can stop treatment. And in the MS community, there's two schools of thought. One of them is you can stop it when people get older. One of them is you should continue all the way. And so us as clinicians don't have the right answer for you yet. So for me to tell you this is what you should do is wrong. I have an opinion on it, but I don't want my opinion to be indoctrinated into everyone as fact, because it's not.
Okay, so Karen writes, so have you seen patients walking, getting worse using Ocrevus? And evidently there are lots of complaints about this.
So again, hard for me to talk about individual drugs. I see people walking, getting worse on every drug. I see people walking, getting better on every drug. So it's not as simple as that. When you see enough patients, you see just about everything. But the short answer is yes, there are patients who do get worse on Ocrevus. There are patients who get worse on just about every treatment out there. There is no such thing as the best treatment in multiple sclerosis. And I'm going to say that over and over again to you. There is no such thing as the best drug. All these drugs have a lot of pros, and all these drugs have some cons. And some drugs work really well in patient A and don't work in patient B, and other drugs work really well in patient B and don't work in patient A. So our brains like to compartmentalize things into good and bad, and black and white, and binary, 0-1. That is not the way this works. And so, you know, always remember that. That's why the first thing I told you is having a clinician who has experience with all different treatments is a really important part of your care. because you start to understand the caveats to all of these medications and know, you kind of know when to hold them and know when to fold them, I would say, with experience.
Sure. Thank you. All right. What are the newest drugs for PPMS and what is in the pipeline?
So there's a variety of things that we're looking at in the pipeline. So the newest drug is Ocrevus. It's the only drug approved for primary progressive MS at this stage. So that is really the only answer for that. We are looking at Ocrevus in a variety of ways. We're looking at elevated doses of Ocrevus in primary progressive patients. There's a new compound called BTK inhibitors that we're looking at in primary progressive disease. There are primary progressive MS is really a final frontier for us that we want to tackle. But we're throwing everything with the kitchen sink at it at this point, trying to find an answer. But it remains a challenge, and it remains kind of on the horizon of where we are. So just know that we are actively enrolling people in PPMS trials. The problem is, in the trials, your ideal PPMS patient is kind of that younger patient who just started their PPMS journey. And most of the patients who are looking for these want a solution now have had this for 20 years and are wheelchair bound at this point. And so it becomes even harder to measure effectiveness because there's not a lot of movement in a lot of these patients. So it's not as simple as you think. And then just by baseline, there's not a lot of PPMS patients.
Okay, thank you for that. All right, next, can you please share some thoughts on cognitive issues? Excuse me, I didn't remember what I said. On cognitive issues and emotions.
Yeah, so this is a great question, actually. So number one, we know multiple sclerosis causes cognitive decline in a lot of patients. So you can develop MS-related cognitive changes. We see it every day. It's very real. It's very pathologic. It's very part of your brain. Number two, understand that your mood affects your memory and your focus a lot. So oftentimes we'll see something that we consider that we might characterize as a pseudo dementia, which basically means that it's a mood disorder that is making it look like you have memory loss or dementia, but it's not real. It's not based in reality. It's not based in a structural change in your brain. So mood is very important when it comes to cognition. When you are depressed, when you are anxious, you have a lot of difficulty focusing, and that in turn starts to feel like I'm so forgetful, or oh my God, they told me 10 times and I forgot. Well, it's not that your memory's bad. It's just that you can't focus on anything other than your mood right now. And so you're not going to, lay that memory down really well.
Okay, thank you for that. All right, Karen, another Karen is asking, do you have patients that had the Medtronic bladder stimulator put in with any success?
I've had not a lot, that's for sure. I know one for sure that I have that it seems to work okay, but we don't see a ton of those. Actually, recently there was a patient who underwent that procedure for us. It wasn't mine, it was one of my partners, and I don't know how she's doing yet. But I do have one, and I think they're doing okay. I don't want to say it's amazing or bad, but I think it's, depends on how bad your bladder is at this stage in the game.
Okay, thank you. For those asking questions that are repeating their questions, please know that I will get to your questions, but I have a lot of questions on paper to ask as well. So please bear with me. I see that your questions are there. You're repeating some of them. And again, I will get to them, okay? So I'm sorry, but I just had to say that because there's a few of them that are just asking again and again. All right, next one on paper. Are there any studies on, and I've never heard this, on brain black versus white brain matter in relation to MS? Or maybe the person is trying to say gray matter versus white matter?
I think they're trying to say one of two things. One, gray matter versus white matter. And so yes, so gray matter and white matter are two different, really it's myelinated and unmyelinated fibers in the brain. So we have a ton of studies that have looked at gray matter versus white matter. What you may be asking is about black holes, I suspect, potentially. So black holes represent kind of areas of really what we call irreversible damage, where there's foundational loss and you've really lost some tissue there. So I can tell you that there are studies on just about everything going on, to answer your question. I mean, there are people who focus on MRI in MS, people who focus on black holes in MS, people who focus on gray matter in MS, and so on and so forth. So yes, the answer to your question is yes, I'm sure someone's looking at what you're asking for sure.
Okay, thank you. And can you tell us, in case that wasn't the thing, but what if the person wanted to know the difference between the gray matter and the white matter?
Okay, so gray matter, so white matter represents myelinated fibers, so fibers that have myelin around them. and gray matter represents non-myelinated fibers. So really, so your brain has some nerve cells with myelin, some without. And that's really all that represents. I mean, so MS is primarily a disease of demyelination, so white matter is heavily affected. However, we also know that that gray matter is affected in MS, and we think a lot of the cognitive issues might be stemming from that as well.
Thank you. There's a person that's asking, do you have any ideas on how to keep your day organized to prevent missing appointments? I'm not laughing at the person asking this, all right? But some of us are so inundated with so many things to do that it doesn't matter how many times you set your alarms in your phone, all right? Because I do, and I just turn them off, all right? And then I forget things. So, Doc, if you have anything you could say about that, that would be great.
I'm probably the worst person to ask that question to. I have somebody who is in charge of my schedule, and they make sure I'm where I need to be. So if you can get one of those, get one of those, because that helps a lot. But what I would say is I think keeping a daily calendar is important, and it needs to be an active part of your day. So if you're having a lot of trouble organizing your day, I would make the most minor thing a part of your schedule. So I would say, coffee and paper, exercise, shower, get dressed, and then go to the grocery store from 9 to 10 a.m., physical therapy from 11 to 2, and try to do as much as you can. And if the more you do it, it takes 21 days to form a habit. So if you just do it for 21 days consistently, you'll end up with a calendar that really makes sense to you, and I don't think you'll miss anything.
And if you forget for 21 days, you'll continue to not remember anything.
Precisely. No.
All right, great. So I do have a lot of questions, though, to ask online. One of the persons, though, that did send in something just a little while ago by text, again, wants to know when it is that your center is supposed to be opening.
So our hope is that we will be in the new center by January of 22. We know that the MRI, the initial phase of the move-in is going to be November, December of 21. So it's a huge ordeal to move 13 clinicians from one place to another, but it will be open by January 22. We should all be in there.
So right now you have the structure of the building all built, and I guess they're moving in all the equipment now?
Yeah, so right now the inside is being done. So I walked through it last week, and we've got hallways, and we've got, drywall people, and we've got plumbing, and we've got all that good stuff. There's a lot of moving parts in there.
Right. Okay, good. Thank you.
The MRI is being set right now.
Great. Is it 3T?
It is a state-of-the-art MRI. It is a absolute monster, and I'm very excited about it.
Great. All right, Marcia is asking or saying, and both, I have relapse remitting, diagnosed in 98. I have OAB and urine retention, and deciding on Medtronic Interstim for the bladder. What are your thoughts or opinions on that? And I'm currently on Ocrevus, and my doctor is stopping my bladder Botox because of the constant bladder infections.
Yeah. So again, thank you for the question. These are very hard to answer, Ben, and I don't mean to be obtuse about it. It's very hard for me to answer personal questions on a case. I'm getting a snippet of your case, and so to give you advice it feels it's just not very thorough and not very professional of me to do. So I don't want to give you any advice on this. What I would tell you is, in terms of Interstim or not to do Interstim or should you do Interstim, I mean, I think that's a conversation you have to have with the urologist in detail and understand the pros and cons of what's happening. This all goes back to what we talked about in the beginning of this and the communication between you and your clinicians. You want to be in a situation where you feel comfortable to get the answers to your questions correctly. Do I think Interstim can help you? If your bladder is doing awful, no matter what, I think you need to do something. And so if the urologist thinks that's the right answer, then that's the conversation you should have with that doctor.
Okay. Thank you. All right. Cindy is writing, in regards to the brain shrinkage that you can see on the MRI, do you ever see parts of the brain, perhaps on the same scan, any part of the brain that is overcompensating for damaged parts and actually looking much stronger than the normal?
Yeah, it's a good question. No, the answer is no, we don't. So never do we see like the right side pulling for the left or anything like that, if there's damage there. The brain is very intelligent, and the brain will kind of find new pathways when there's damage. And so there's a reason that you get recovery after an attack, and a stroke patient gets better 3 months after their stroke in some instances. So the brain will try its best to find ways to maneuver about damage to continue to function as much as you can. But we can't see that on scan, no.
So realistically, thank you. The brain, therefore, is realistically relearning, reteaching itself.
Absolutely. That's why we push rehab so hard on you.
Okay, great. All right, Catherine is writing, I'm on Aubagio and have been getting worse in terms of walking. Does that mean that the Aubagio is not the optimal drug for me? What would you suggest? I know it's personal, but that one you might be able to answer.
Yeah, I mean, I can answer a little bit. I mean, this is a common question where patients are getting worse. So first, we got to figure out why you're getting worse. What's actually getting worse? Are you 65 years old and developing lumbar stenosis? That has nothing to do with your MS. Do you have peripheral neuropathy related to diabetes? That has nothing to do with your MS. Do you have cervical stenosis and that has nothing to do with your MS? That's causing your walking to get worse. So you have to remember, guys, when you have MS, it doesn't mean everything that's happening is from the MS. So there's many things that happen to everyday people who don't have MS as they get older, and they have trouble walking and they trip on themselves and so on and so forth. So the first question is, it's not as simple as saying the Aubagio is not working. If we make sure there's nothing else going on and you continue to progress or continue to worsen, it's not that the Aubagio is not working. The Aubagio is not meant to be a cure for your MS. Now, that doesn't mean that changing treatment might not help you. So that's a conversation that you might have with your doctor. But all these drugs are not meant to reverse aging and reverse normal worsening of life. I'm 40 and I can't do what I did when I was 20. I can tell you that right now. And it's not, it's not a medication that's causing that. It's my age.
Yeah, thank you for that. And thank you for the message earlier that you said something about being over 60. I mean, yeah, that hit on me too. I'm now at a ripe 62, okay? And I don't want to hear about it. So, all right. All right, so a few questions remain, one of which is from Kay. She would like to know your opinion on intermittent fasting for MS.
Yeah, so it's great. So I'll give you my opinion in general on intermittent fasting, not for MS. I believe in intermittent fasting. I'm a huge fan of fasting. I've read all the studies in the oncology research surrounding chemotherapy and fasting. I practice fasting. Two of our neuroimmunologists fast regularly every week, myself and one of my partners. So we are firm advocates of it. We believe there's no question that we tend to overeat, we tend to overfuel, we tend to eat a lot of junk, a lot of processed food, and none of that is helping us. Can I tell you it's going to help your MS? No, I don't have that data. But I can tell you that it ain't going to hurt it. And I can tell you what can hurt it is a cheeseburger and fries from McDonald's every 4 hours, so.
Right. Exactly. Thank you for that. And also, what are your feelings on the Mediterranean diet?
So the Mediterranean diet, I think, has great kind of cross health benefits. So there's enough evidence for it in the cardiac space to know that it's helpful. So I would rather you be on the Mediterranean diet than our normal American diet. How's that?
Sounds great. All right. For those that don't know, the Mediterranean is on by the Middle East. Okay.
Yes.
All right. Great. All right. Next, Mandy. I'm so thankful to be part of the Owasso Memorial MS Care team. They all rock, she says.
Oh.
And then she also says, I should have said a patient of the Owasso Memorial MS Care team. All right. So that's great. Thank you for that. And another person, Catherine, is asking, she lives in Canada. Can she be a patient of yours?
Yeah, of course. I mean, I'm willing to see anybody. I don't care. My staff will kill me and someone will find a bureaucratic nightmare around it, but I don't care. I'm happy to see anybody when it comes to helping. I don't, that part of it. Yeah, we can work through all those little things. Absolutely, you can.
Great. Will Canada allow her back into Canada after being in the United States?
I don't know what they're doing now with COVID in Canada.
I don't know either. I have no idea.
Wasn't Ottawa on martial law or something like that recently?
I cannot even answer that. As I told you before we began this program, I haven't seen the news in weeks. I have no idea what's going on.
Yeah.
All right. Next, if you get foot drop, does that mean your MS treatment is not working?
No. MS patients will get foot drop very often. and they will get iliopsoas or hip flexion weakness very often. It tends to come with MS in a lot of patients, not all, but a lot of patients. Doesn't necessarily mean your drug's not working. If you suddenly develop foot drop and it represents a new relapse, then that's a big concern. And yeah, your drug may not be working. So it can be a little bit of this, a little bit of that. It depends how it develops, how slow it develops, over what period of time, how long it lasts, how severe it is.
Okay. And this last one, okay, last question. A few people have written it, and from different medication standpoints, they're on different MS medications, and they're thinking of going to Ocrevus. Shouldn't they have a more definitive reason of going?
Yeah, I mean, I think, look, Ocrevus is a great drug, and we use it quite a bit, but we use everything quite a bit. And so I would say, you know, as a population, as a patient, I want you to be health literate, meaning I want you to understand what's out there. I want you to know about Ocrevus. I want you to know about, but I also want you to be able to tell me the names of the other drugs too, so that when we sit in the room and have a conversation, it's not just the one drug that you can pronounce or that you know about. So, you know, don't think that one drug is the end all be all for this and we're done, because you know, it's just not the case. I mean, you know, we use a ton of. Today I wrote 6 different MS treatments, you know, and 6 different patients, and one of them was Ocrevus, you know, and so you know, I think a lot of patients are, as much as you're health literate, you're also inundated with advertisements and that kind of thing, and so it becomes, you know, now you're seeing commercials now, so there's commercials now for some of these drugs. So Ocrevus is a fantastic drug. But to tell you that that's the only drug we use would be a complete lie. I mean, there are other fantastic drugs. So just know what's available.
Thank you. And it was going to be the last question, but somebody had to sneak one in, and I'm going to ask that nobody else does send in another question, because the doctor needs to get going. All right. And I've only got 3 minutes left with him. All right.
Oh.
So this next person asks, do you suggest stem cell transplant? That's a good enough question to bring up.
A great question. So do I suggest it? Well, legally in the US, we don't do it for patients, so I can't suggest it. The data on stem cell transplantation, on true hematopoietic stem cell transplant, is very intriguing. And one of my partners here deals with most of our patients who get stem cell transplants from other countries. So she kind of does that as a specialty, so to speak. And she's seen very good results. So I think there are still safety concerns that we need to vet before it's prime time, and they're very real safety things. So it's not as simple as just get a stem cell transplant. But again, they're not as scary as they were several years ago. So I think we're closer to that, and hopefully we'll be able to kind of dive into that in the United States at some point in the next couple of years. Here is my hope, 3 years, and go from there. But yes, they seem to work very well when they're done right.
Thank you. One of my concerns with the stem cell treatment that I've addressed with many people is that, what if something happens? I mean, you might have this done in Jamaica or in Mexico or Russia, all right, and something happens to you. How are you going to get back there? I mean, and how is your local doctor, your local neurologist, going to even know what to do for you?
Yeah, it's a challenge. I mean, the bigger one that I would say is understand that stem cell transplants, a lot of patients who ask about stem cell transplants are really chronic MS with a lot of disability. And they have an idea that it's going to regrow something, and that's not the case. You know, really, the stem cell transplant, if you're going to do it, ideally, is very early, when you first get MS, and you just change the entire immune process. You know, so just remember that too. A lot of people think it's like this regrowth of something, and it's not.
Okay, great. Well, doctor, I want to let you know we had an awesome event here tonight, and it was an extreme pleasure to hear you and your responses and the way that you handled everything tonight. And it was absolutely fantastic. I can't wait to speak more with you, and I cannot wait to get into your schedule so we can get that happening done at the health, at your new neurology center. And also, we will definitely be coming up towards the end of the year to do a in-person program, socially distanced, of course. We have our own algorithm for doing that, and we are going to be starting to do that. For everybody out there, we are going to be starting to do this in June. We're going to be in Columbus, Ohio with Dr. Boster, okay, doing an in-person event, and hopefully every other month through the end of the year, we'll be able to continue doing this and finalizing the year in Owasso. and doing it with Dr. Aburashed. Okay. So for tonight, though, I do want to thank everybody for being online. I want to thank the doctor. He's got to run home now. He's got kids to take care of. And everybody, I want to wish you a great night. Doctor, thank you for being again with us. And everybody online, thank you. And let's thank our supporters of tonight's program, because without them, we could not do this. Everybody who's out there, get your damn vaccine. I used to say, get your damn mask, wear your damn mask. And now I'm going to tell you to get that damn vaccine. All right. Let's make this United States a safer place to live. Okay. Thank you.
Thank you. Thanks, everybody. Have a great night. Thanks, Stuart.
Thank you. Bye-bye.